Hello everyone, and thank you for joining the Urologist in Cancer Care video editorial series on OncLive Peer Exchange. This video series features expert panel discussions on treatment challenges and practice management issues faced by urologists who care for patients with cancer. My name is Raoul Concepcion. I'm a practicing urologist specializing in urological oncology and the Director of Clinical Research at Urology Associates in Nashville, Tennessee. I'm also the immediate past president of the Large Urology Group Practice Association. Today's panel discussion is a continuation of our series of discussions on managing prostate cancer patients effectively in a urology practice setting. These videos can also be found on onclive.com. I have the privilege of moderating today's discussion. We'll address a range of issues from data on the many new treatments for prostate cancer to reimbursement and other practice management issues. Our goal is to provide urologists with a range of expert perspectives on current challenges that affect your patients and your practice. For today's panel, I am joined by leading experts and frontline practitioners with a wide range of experience in these areas. Dr. Daniel Saltzstein is Medical Director of Research and Advanced Prostate Cancer Clinic at Urology San Antonio. Mr. Steve Dobbs is Chief Executive Officer at Urologic Specialists of Oklahoma, a 20-physician single specialty group in Tulsa. Dr. Bryan Mehlhaff is the Director of Clinical Research at Oregon Urology Institute in Eugene. We will also be hearing from Dr. Neal D, who is a practicing clinical urologist and medical director at the Carolina Urologic Research Center in Myrtle Beach, South Carolina. Thank you all for joining us today, and let's go ahead and get started. Let's talk about prostate cancer in terms of its disease as a continuum. And what we're looking at here is the slide that I think many of us have seen, which basically depicts prostate cancer from diagnosis all the way through death. I think urologists in general have been obviously very, very instrumental, and I think most of us believe that it is the urologist that is the purveyor of prostate cancer. We are very good at making the diagnosis because many of these patients are referred to our practice due to an elevation in their prostate-specific antigen level, or their PSA. We do the biopsies, we offer definitive therapy, and fortunately, 70% of prostate cancer patients after definitive therapy do great. But we all know that about 30% will fail, and they initially fail by this initial rise in PSA. So, androgen deprivation therapy, or ADT, is still used as the early treatment for advancing prostate cancer in patients who have failed definitive therapy. And as we know, androgen deprivation therapy lowers androgen levels and stops androgens from facilitating the growth of prostate cancer cells. In my mind, it has served as the cornerstone, if you will, for these particular treatments. We also know, however, that patients will eventually fail androgen deprivation therapy. And as the slide suggests, is that once again, that is manifested by a rise in PSA levels. Now, I would say that up until this point, urologists have pretty much managed that patient through that section of treatment. But once they start to fail hormonal therapy, that's when most practicing urologists at that point have turned management of these patients over to the medical oncologist.